Today we will be going over a study on pneumothorax presented by yours truly. Our table of contents is pretty simple and will proceed like so, starting off with our introduction, our general description, our history, the etiology and epidemiology, our symptoms, studies conducted, treatments and therapies, and we will wrap up with our statement of learning. A pneumothorax is a common occurrence in the field of medicine. Cases range from motor vehicle accidents, secondary from an underlying cause, or to just adults that are growing too fast for their own good. Officially, they can be classified as closed and open, but we'll touch base with that later. They can be further classified such as traumatic, spontaneous, and iatrogenic. Traumatic is your typical chest wound, someone coming up and stab someone in the chest. Spontaneous is for your kid that's already 6 feet tall and is already hitting another growth spurt. And the iatrogenic is basically the hospital's fault. Either way, most cases are confirmed via chest x-ray, but there are many other observations and assessments you can catch to aid in your confirmation. Sure, you might think you're ready to counter a pneumo in the field, but it is better to be fully prepared before treating this condition. Well, what exactly is a pneumothorax? This term simply refers to the presence of air within the pleural space, or where air is not supposed to be at. It's usually characterized by recurrent complaints of chest pain with some degree of dyspnea. Once this gas is in the pleural space, it enhances the lungs' tendency to recoil, as well as the natural tendency of the chest wall's ability to expand. Naturally, the pressure inside your pleural space resides at roughly -5 centimeters of water pressure, until gas or positive pressure violates the tranquil conditions of cardiopulmonary harmony. And there's a number of things that could disrupt this harmony, such as fluid, yada yada, but particularly in this case we're talking about gas. Before we dive off face first into this, let's take a break and touch base on the history of the pneumothorax. Yes, this might be a boring portion, but it is good to touch base on the origins, and you might figure out something you didn't know that could help you today. And it's better to learn now than in the field. Anyhow, pneumo is actually of Greek origin. Surprise. It's tough trying to find actual documentation of this back then, but if you go to Crofton and Douglas's Respiratory Diseases, 4th edition, this is actually inferred as early as 5th century and was called the Hippocratic succession. Or at least the practice was called that. Diagnosis of this completely threw patient comfort out the window, and they would violently shake their patient in an attempt to hear a splashing noise around the thorax. Turns out later this is actually pleural effusion, but they had the right idea. As far as the history of pneumos go, nothing really interesting happened until about 1988. Bam, some genius figured out a way to use pneumothoraxes in TB treatment. These were called collapse therapy and artificial pneumos. Up until the 1950s, when antibiotic therapy was available for TB, artificial pneumothorax and collapse therapy was paramount for lowering mortality rates. And for those that weren't fortunate enough to actually have the antibiotics and had to go through the collapse therapy, continued to live for about 50 to 60 years, so someone was doing something right. But like I said before, in the 1950s they came up with anti-tuberculosis treatments. So artificial pneumothorax and collapse therapy became obsolete. However, surprise again, there is still one country that still practices it, and it is Greece, and it's still on the official list of procedures that the state will pay for. Moving on. Earlier we touched base on the types of pneumos and what could have caused them, but now it's time to dive into the etiology and epidemiology of this. Not only is pneumo of Greek origin, but it also stands for air. You add thorax to it, you got air in your thorax. Earlier we mentioned the two main classifications, open and closed. It's fairly simple. Open means exposed to atmosphere, closed is closed off from the atmosphere. Well, how does gas enter the thorax? Well, gas can enter the pleural space from the lungs through perforation of the visceral pleura from the surrounding atmosphere and from gas-forming organisms. Once this happens, they can be further classified into the other classifications we talked about earlier: traumatic, spontaneous, or iatrogenic. Traumatic pneumos are the ones you really want to be prepared for. They occur from penetrating wounds, i.e. a bullet or a knife. When this happens, the pleural space is in direct contact with the atmosphere, moving gas in and out of your pleural cavity, otherwise known as an open pneumothorax or a sucking chest wound. Sometimes they can turn into closed, but not in our case here. The check valve and air won't be able to escape. This builds the intrapleural pressure up until it exceeds atmospheric pressure, classifying as a tension or valvular pneumothorax. These are the bad ones. They can turn from okay to really bad really quick. As the victim struggles to breathe, transpleural pressure rises, further compressing the affected lung. It's a lose-lose situation. Now we have our spontaneous pneumos. These are identified by sudden onset without any obvious reason for the cause. They are usually secondary to other pathologic processes, such as pneumonia, tuberculosis, or COPD. For example, you got yourself a COPD patient, it's got Ebola about to rupture, and pop, you got yourself a leak. Once again, you got gas moving into your pleural cavity. In some cases, the tear will act as a valve, and once again, pressure will build, and this is labeled as both closed and tension pneumo. Finally, we have our iatrogenic pneumos. These occur in the hospital settings during medical procedures. Basically, it's the hospital's fault. Let's say you're going through a bronchoscopy for a COPD patient, and you hit the gas when you should have hit the brakes, and you wind up popping his bulla near the surface of his lung. Boom, pneumo. Procedures that can cause this can also vary from liver biopsy to tracheostomies. Out of all this chaos, the user comes with a few symptoms that can be measured at the patient's bedside. Out of the cacophony of symptoms that a pneumo produces, there are a few that stand out. Officially, they could be confirmed via chest x-ray, but let's say we don't have that yet, we're just using our eyes, ears, and hands. First thing you would see, obviously, the patient would be tachypnic. Not only is the high respiratory rate influenced by the pain and anxiety, the work of breathing has markedly increased. The partial or fully collapsed lung has forced the body to double the effort to be able to operate on a decreased lung function, in severe cases, one lung, to meet the body's oxygen requirements. Another major symptom to note is the shift in the trachea. You will literally see the trachea deviate a couple of centimeters from the affected side. Everything inside your rib cage is moved to the side from the change in pressure from negative to positive, as well as your body doing what it needs to do to shift organs in a consolidated manner in an attempt to maintain proper ventilation. Auscultation will reveal diminished or no breath sounds on the affected side. This will also reflect improper chest rise. Touching back on the chest x-ray, that is, by the books, how to confirm a pneumo. The presence of a pneumo is pretty obvious if you've done your radiologic homework and know what you're looking for. First of all, you will notice an increased translucency in the affected side with a depressed diaphragm. One will also catch that the contents of the mediastinum are shifted away from the affected side. Atelectasis will also occur as the positive pressure compresses the lung, which may lead to total lung collapse. All of these findings are pretty easy to see, especially in severe cases. Symptoms go on, but these are the key ones, and it will be wise to remember. Sometimes they could be easy to miss. In the ICU, roughly 30% of them are missed. So one won't always have a fancy machine with the bells and whistles or a pulmonologist available to confirm your suspicions. and you have to deal with the tools you have at your disposal. Like any other disease or condition, there is a couple interesting studies that stand out. Primary spontaneous pneumos, or pneumos that occur with no underlying lung disease, usually occur in patients in their teenage years or early 20s. Around 90% of these cases involve smoking risk as a factor. An interesting study with a persistent spontaneous pneumos suggests that there is a better procedure than treatment thoracoscopically. The Endo-Floating Ball 3.0 is an endoscopic device used for liver resections. Study of application of this device to treat blebs that might rupture show results comparable to standard thoracoscopic treatment. Keeping invasiveness to a minimum, 2 incisions are made in the axillary triangle. Thoracoscope and endofloating ball go in, treatment is administered and may be coagulated with saline-cooled device. This technique minimizes damage of the visceral pleura, which in turn means less air leakage. Now that we've endured that gauntlet of information, let's treat it, shall we? Treatment of pneumos depend on the degree of lung collapse and classification. In cases that involve 20% or less, bed rest and limited activity is advised. Easy, right? The trapped gas will naturally be reabsorbed within 30 days. In cases involving more than 20% collapse, things get pretty interesting. The gas should be evacuated via thoracostomy chest tube. This chest tube is connected to negative pressure to suck out the air. The tubing is routed through the underwater seal and is then inserted into the pleural cavity. This tube continues under coastal grooves until it reaches the anterior apex of the lung because gas will rise and patients are placed in a manner to allow proper gas movement. This negative pressure procedure sort of simulates the natural environment of the lung, all the while promoting the use of lung expansion. Once all the extra air has been pulled out, the bubbling stops at the underwater seal, and the chest tube is clamped off and left to heal for 24 to 48 hours. This treatment can be used in both adults and children. The chosen tube size will vary, of course. Administer oxygen, of course, but don't worry too much about the hypoxemia until you have treated the underlying cause or add some sort of lung expansion protocol. While O2 might aid in oxygenation, it won't help until true gas exchange occurs and the alveoli are reinflated to allow ventilation and perfusion. Use lung expansion with caution. Too much PEEP or positive end expiratory pressure can cause more ruptures or make the situation markedly worse. In some severe cases, acute ventilatory failure may develop and patients with a pneumo may need invasive mechanical ventilation. On rare occasions, a pleurodesis may be the choice of treatment. In cases when recurrent pneumothoraxes occur, during a thoracentesis, a sclerosant agent is administered. This agent causes an intense inflammatory response over the outer surface of the lung, sealing it to the chest cavity in an attempt to prevent or reduce recurrent pneumos. While this procedure may be effective, it does produce an intense pleurisy. So as a writer and as a student, what I've learned to take home is what exactly a pneumothorax is, its history, how it works and what it does exactly to the body, how to identify it with or without a chest x-ray, and hopefully how to treat it. Now that one has all this information handy, what can be done with it? One, or as the reader, should be able to identify and treat a pneumothorax. This condition has a fine line where it can turn from manageable to bad fast, and it's something that occurs more often than you think. It is good to be prepared, because in critical thinking, in tense situations such as these, it's crucial to piece together the solution, but without the proper information for treatment, it's rendered useless. Adequate preparation is vital for treating conditions in the hospital setting. Prior planning prevents piss-poor performance.